before we get into the episode, I've got to tell you about something that I use all the time, and that's my X shears. These aren't your run-of-the-mill trauma shears that bend after one tough shift. X shears were designed by someone who gets it. A nurse and paramedic who is just tired of disposable junk and clunky tools that never held up. Y'all, these things are beast. Heavy-duty, stainless steel blades, the titanium coating, super comfortable non-slip handles, and yeah, they come in a bunch of colors, including my favorite, purple. They're easy to clean, built to last, and come with a 5-year warranty, which is basically unheard of. And this is new, the X Shear Mini. It's only 6 inches, and it fits in your pocket or a small kit. It still cuts like a champ, but it's perfect for those lighter situations where you don't need the full-size version. So, wherever you care for patients, you want a pair of shears that actually work, and X Shears is it. I promise they'll be your new favorite shears. And you can use the code RAPID10 to get 10% off your purchase. So check them out. I put a link in the show notes for you.
What's going through my mind, Sarah, honestly, this is really bad, and modeling really terrifies me. Modeling usually means that we've been dealing with end organ hypoperfusion for quite a long time. Modeling is not a good prognostic indicator. There are pieces of this puzzle that are not fitting into the septic shock picture. The fact that he is cool and clammy to the extremities does not really fit with someone who is in vasodilatory shock.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Run podcast. Today, we're diving into a condition that can complicate the already critical diagnosis of sepsis, and that is sepsis-induced cardiomyopathy. This is a phenomenon where a patient in septic shock not only faces vasodilation and distributive shock, but also develops myocardial dysfunction that makes their care even more complex. I'm joined today by Dr. Mahmoud Ibrahim, an intensivist with expertise in both critical care medicine and pulmonology. We're going to walk through an evolving patient case together, and Dr. Ibrahim will help us break down the pathophysiology, the diagnostic clues, and treatment strategies for sepsis-induced cardiomyopathy. So, Dr. Ibrahim, welcome to the podcast.
Thank you so much, Sarah. I am so psyched to be here, and please call me Moody.
Moody it is. All right, Moody, let's do this. So the way that I want to walk through this topic is through an evolving case study. I know we've said this before that we wish we could work together in real life, that we weren't just internet nerd buddies. Yeah. So this is our chance to do a case together. So let's pretend that we are working at the same hospital in our dreams. You're the intensivist covering the ICU today, and I'm the rapid response nurse for our facility. There's a patient that's going to crash, and we're going to uncover his diagnosis together, just as if we were both responding to a rapid response call together. Sound good to you?
Sounds amazing. I love this hypothetical scenario.
Okay, let's do this. Let's save a life. All right. This is the case study of Mr. James. It is 1400. You just sat down with your lunch, of course, when the rapid response broadcast goes off. So you head towards the progressive care unit, and we arrive to the patient's room at the same time. From the doorway, we see a patient on a heated high-flow nasal cannula with increased work of breathing and the following vital signs on the monitor. Heart rate of 132, blood pressure 82/50, respiratory rate 32, and oxygen saturation is 86% on the heated high-flow nasal cannula flowing at 60% FiO2. So the primary nurse provides us a brief history as we're walking in the door. This is a 62-year-old male, history of type 2 diabetes, hypertension. He was admitted yesterday for a fever, cough, shortness of breath. His chest x-ray showed right lower lobe pneumonia. We started him on antibiotics. He's had 2 liters of fluids in the ER. He came up to us on high-flow nasal cannula at 50 liters per minute with an FiO2 of 60%. This morning, he just seemed more tachypnic and restless, and his blood pressure keeps dropping. He's been fluid responsive until now, and that's why I called you guys. Okay, so Moody, just with that initial information, vital signs, history, what are you thinking? What are your priorities as the provider?
This is a great case, and there's already so much to unpack, and I'm already so excited to do it. I would say, one of my previous mentors said the 3 most common reasons people come to the ICU, at least the medical ICU, is hypoxemia, hypotension, and altered mental status. And so Mr. James is in a lot of trouble because we have an airway issue, an oxygenation issue, and we also have a hemodynamic issue. Now, the context is super, super helpful. We already know that he is 60 plus years old and he has diabetes. I think a lot of people gloss over how diabetes can be an immune compromising risk factor. So he's already someone who has certain risk factors for sepsis. And then you throw in that we know that he has pneumonia, and now we know he has some end organ damage with his hypoxemia. This is all sounding very much a diagnosis of sepsis related to pneumonia. Now, the interesting part is something has developed here where he's not responding appropriately to our treatment. So either we have now stepped into septic shock because we're becoming hypotensive despite fluids, or something new is going on that we are not paying attention to. So my priorities, it's going to take us a while to find out what we're dealing with, is getting him to a comfortable respiratory and hemodynamic status. So this is a good time to move him down to the intensive care unit. If he's already on a high flow and he's still desaturating, I would be cranking that FiO2 up higher. I would be increasing that flow. I would probably be calling our respiratory therapist to see if we can get a BiPAP. This is a situation where an X-ray would actually be really helpful, just to take a look and see what is going on in his lungs. Are they full of fluid? Why is he becoming hypoxemic? I always tell people, if someone is struggling to breathe, fluids are almost never the answer. So I don't think the fluids are helping in this situation. And I do think that if we've already given 2 liters of fluid and now we're going into respiratory failure, definitely time for vasopressors so we can back off the fluid and see what we're dealing with.
Okay, I love it. Well, me and you are on the same page. So
Cool.
I'm going to let you go ahead and approach the patient, do an assessment, and I'm calling respiratory therapy to get him to bring a BiPAP.
Yeah.
I'm probably going to go myself adjust the FiO2 because we have a low sat and we're only giving FiO2 of 60%.
Right.
Yeah, so we're going to go up on that a little bit. Okay.
Right.
All right, so you approach the patient, you do a quick physical exam, and you find the patient's definitely dyspneic. You saw it from the doorway, and now you're pull back the covers and see all these accessory muscles that he's working with. His skin is cool. It's clammy. You pull back the covers. He's modeling at the knees. Got weak peripheral pulses. He is altered. So he answers questions, but it's slowly. He's kind of intermittently confused. His lung sounds have crackles throughout. Okay, Moody. So you see hypotension, tachycardia, moderate extremities in a septic patient. What's going through your mind? Differentials, priorities? Go for it.
What's going through my mind, Sarah, honestly, is this is really bad. This is really bad, and modeling really terrifies me. Modeling usually means that we've been dealing with end organ hypoperfusion for quite a long time. And we've got a lot of capillary leak and a lot of damage to our endothelial lining of our blood vessels. So modeling is not a good prognostic indicator. There are pieces of this puzzle that are not fitting into the septic shock picture. So someone who has sepsis, the hallmark of sepsis is this cytokine storm and this nitric oxide explosion in our blood vessels. Our capillaries get very leaky. Our blood vessels get very floppy, and patients get really warm, bounding pulses. And so the fact that he is cool and clammy to the extremities does not really fit with someone who is in vasodilatory shock. So that kind of raises a red flag to me of why is he cool and clammy? That doesn't make sense. That's not classic of sepsis. And now we know that he has crackles in his lungs. So even before we get that x-ray or get our ultrasound probe to look for B lines, we know this patient has pulmonary edema. So at this point, I'm saying, hey, Sarah, let's turn off that fluid. I don't think it's helping anymore. Definitely time to turn up the vasopressors. and, consider whether we actually might need to go the other way and even diuresing this patient at this point. So there's something in this story that's not picking up. And the fact that he's getting more lethargic tells me that I don't have a whole lot of time to figure it out. Starting to worry, are we heading towards an intubation pathway? We really got to improve our perfusion like ASAP.
Yes. Okay. I can't agree enough. I wanted just to echo the modeling piece.
Yeah.
I feel like this is something that wasn't stressed to me enough in my training, but enough patients that you see modeled then crump, it kind of gets ingrained into your thought process that this should be concerning.
100%.
The other thing too, I wanted to point out, this guy does have some hypotension, but I have seen patients who are still compensating. They still somehow have a, quote, stable blood pressure greater than 90 systolic. And everyone's like, oh, no, they're fine. They can stay PCU. Their blood pressure is 91 systolic. But you pull back the covers and see modeling of the knees, and that to me should be upgrade to ICU. Just because we know, they're compensating. Look how hard they're compensating. They got blue kneecaps. And so, yes, I agree with you. I definitely see a sepsis picture building from his history, from his x-ray. Like, the story looks very sepsis-y, but these cool model extremities, what's going on with the perfusion? Like, why?
Yes.
Why are we not perfusing the extremities right now? Okay, very good. So while you were assessing the patient, I was talking with the primary nurse, getting a little bit more information. They say the patient hasn't had any urine output all shift. It's 1,400, Moody. The nurse scanned the patient's bladder. There's only 80 mLs of fluid in the bladder. But this patient's received a total of 3 liters of IV fluid since admission to the ER till now, which that's not uncommon. You say sepsis, ER says fluid boluses. Understandably so, right?
Yes.
The blood cultures were drawn in the ER. They're still pending. The lactate from the ER was 4.6. Okay. So my questions for you are, how do you want to treat his blood pressure? I heard you say vasopressors, but specifically, which ones do you want? And then what diagnostics do you want to get from here?
Great questions. I think there's so many useful clinical pearls, even in everything you've said so far. So the first one I would highlight is the fact that blood pressure and perfusion are not the same, and that blood pressure is a combination of our cardiac output and then our systemic vascular resistance or our total peripheral resistance. And different patients will need different blood pressure targets to perfuse their vital organs. So you made a great point earlier that patient with a blood pressure which was seemingly acceptable was not perfusing. And sometimes you can have patients who are even hypertensive and still not perfusing. So important to make that delineation of, hypotension versus shock. And then in this gentleman, the thing that I'm worried about now is, okay, so we're going into shock. At this point, it's septic or undifferentiated. One of the things that I'm thinking about is antibiotics. So hopefully this gentleman has gotten broad spectrum antibiotics, and I would be looking back to see, what antibiotics has he gotten? At this point, I would make sure that we're covering for things like MRSA and Pseudomonas. So if he just got community-acquired pneumonia coverage with ceftriaxone and azithromycin, I would be broadening that at this point. If we're going into septic shock, we need to have broad-spectrum antibiotics. You mentioned that he got blood cultures as well, which is fantastic. The other thing you mentioned is a huge red flag for kidney failure, right? So even before this patient's basic metabolic panel comes back and tells me what his creatinine is, the fact that he is anuric, despite getting all these fluids now for like 8 hours, this gentleman's in kidney failure. How bad? I don't know, but he's in kidney failure. And he's in the worst kind of kidney failure where he's not making any urine. So regardless of what his creatinine is, I'm super concerned. And we know that he's in pulmonary edema and hypoxemic. So this kidney failure is going to complicate our respiratory status big time. If we can't get some fluid off of him, we're moving quickly towards intubation. Now, in terms of diagnostics, I would love to get an x-ray just to see what we already expect to see, the pulmonary edema. I would also love to get an echocardiogram. So echocardiogram would be extremely helpful at this point just to see what's going on with the heart. Does it have a normal ejection fraction? Rule out some other big causes of shock. So is the right ventricle super swollen with a McConnell sign? Do I need to worry about a PE? Now, someone who already has a ton of fluid in their lungs, I have a good reason for them being hypoxemic. So PE kind of drops down. Someone with a normal x-ray and hypotension, hypoxemia, PE moves way, way up, but still, I'd look at that right ventricle. The other big thing is looking at the pericardium, just seeing if there's a huge tamponade, something else that could be going on. So an echo could give me a lot of information at this point. So I would say definitely some basic labs, EKG, echocardiogram, x-ray, all those things would help me a lot.
Okay, awesome. So what I'm hearing is you don't want to give fluids to fix this blood pressure. Is that correct?
Oh my God, no. Oh my God.
Okay.
This is one of those situations where I will have like a mini stroke where if I see people continuing to give fluids when A, the kidneys are not responding to it, and B, the patient is getting into worse respiratory failure. In my mind, we have gone from helping the patient to either not helping and potentially harming. You know what I
Yeah.
mean? And we know from a good amount of trials that have come out in septic shock that the amount of fluids that we give does not make a huge difference. This 30 cc per kilo thing that is in the guidelines, you'd think it would be built on like amazing data. It is built on terrible data. It is literally a number that is pulled from like observational trials. So it is really not that important to give 30 cc per kilo for everyone. You need to resuscitate your patient, individualize it. And in this patient who's anuric, on high flow, in severe hypoxemia, no fluids.
Okay, got it. All right. So what would be your vasopressor of choice for this patient?
Yes, thank you for bringing me back to that. Norepi is the way to go. Norepinephrine is the way to go until I have a better explanation of what's going on. Norepinephrine is first line in septic shock. It is also first line in undifferentiated shock, which is what we're dealing with now. So I would be leaning for the norepi. It's got that predominantly alpha agonism to squeeze the blood vessels and raise the blood pressure. It's also got a little bit of beta agonism to give the heart a little bit of support for that increased afterload. So norepi to start off.
Love it. All right, we're going to do some closed loop communication. So doctor, I hear you. I called lab. They're getting some blood work started. I've called for a stat echo. They're going to be a little bit.
Okay.
I have my point of care ultrasound in my backpack. I'm happy to let you use that. I'm going to take a peek-see. I am mixing norepinephrine. I'll get that started to maintain a map of greater than 65.
65 sounds good. Mm-hmm.
Okay, sounds good. All right. So I'll hand you my ultrasound so you can do a little POCUS exam because echoes, it'd probably be 30 minutes till we actually get a bedside echo.
Right.
So your bedside ultrasound reveals left ventricular ejection fraction is around like 30%. Globally reduced though. The LV does appear dilated with a pretty sluggish squeeze. The IVC is plethoric with minimal respiratory variation. The lung ultrasound shows B lines confirming pulmonary edema and lung sliding to rule out pneumothorax. Okay. Will you just kind of unpack that for a second while I'm getting this norepinephrine started?
Yes, definitely. Okay. Let's start with different pieces. So the fact that the inferior vena cava is plump and it is not having respiratory variation is giving us a signal that the pressures in the heart, especially the right-sided pressures, are very high. This heart is already struggling to manage all the fluid and all the preload that is coming back to it. It cannot handle any more venous return. We need to stop our fluids ASAP. This heart is in duress. The second big piece of the puzzle here is look at that ejection fraction. So we know less than 50% and definitely 40% and less characterizes as systolic heart failure. So now my brain is thinking, that's interesting. Most patients with, textbook septic shock are going to have a normal ejection fraction, maybe even a hyperdynamic ejection fraction. So why does this patient have heart failure? And is this heart failure new or old? And what's causing it? I think the most immediate thing in my mind right now, actually, is this patient having acute coronary syndrome? Because if they are, that changes our management big time. Like if he's having a STEMI, we need to get him to the lab ASAP, revascularize his coronaries, and fix that heart. So that's really would be the biggest thing is, first of all, that's odd. Why is his ejection fraction low? Is this new or old? Do I have an old echo? And is there something that needs to be time sensitively managed right now for this heart? Is he having chest pain? Is there EKG showing STEMI? But that definitely is sort of a turn in the path we were going down.
That's good. So you make an important point. Our listeners know we're going to be talking about sepsis-induced cardiomyopathy. Yes. So they know the diagnosis already. But me and you, we're like at the bedside, we're figuring it out. So you're right. We do need to rule out a clogged coronary as a potential source for this cardiomyopathy, right? Why is the left ventricle not squeezing well? Is there lack of flow because of the pipes need to be cleaned out?
Right.
Let's rule it out. Okay, so I'll call for that EKG, and we already sent a troponin, so we can kind of keep an eye on how that's trending. Very good. But just to review, we are seeing something we don't always expect to see in septic shock. We see low ejection fraction, poor contractility. So not only do we have distributive shock, as evidenced by his blood pressure and all the other history of his diagnosis, right? But we're also looking at cardiogenic shock as well. We see that on ultrasound, and we see that in his poor perfusion, his extremities. Okay, so now we get to get real nerdy. I know in real life we wouldn't have time for this. We'd have to talk about this later, Moody, but real quick, can you just explain what's happening at the cellular and cardiac level in sepsis? Like how how can sepsis lead to cardiomyopathy instead of just distributive shock? Like, what pathophysiologic mechanisms are at play here, and how does this complicate our management of this patient?
This is a great question, Sarah. Sepsis-induced cardiomyopathy is a very, very interesting pathophysiology to nerd out about. So from what I understand, this sepsis-induced cardiomyopathy term has been around for like over 4 decades. And what we know about it is that it is not a perfusion problem to the heart on a macro level. So if you were actually to like shrink in, like from Honey, I Shrunk the Kids, and get into the coronary vessel and be traveling in the coronary vessel, the coronary circulation is actually normal. It might actually even be increased. So it's not that the coronaries don't have blood going through them. There's a lot of disease happening on a microcellular level. So what is happening is this cytokine storm, right? And you hear this term cytokine all the time when it comes to sepsis. So what are cytokines? They're basically this chemical messengers that are moving this sort of like concoction of chaos throughout the body. So what happens is there's something on the actual microorganism that's causing the sepsis. They're called pathogen-associated molecular patterns, basically specific patterns that your body says, that's not part of us. Let's activate alarm signals and send out cytokines. And then as the body's cells start dying as well, there's other types of cells called damage-associated molecular patterns that the body goes, the cells are dying. Let's send some more cytokines. And you end up getting this cytokine explosion. And you're like, okay, but what does that have to do with the heart? What happens in the heart is on a cellular level, the mitochondria get attacked. There starts to have mitochondrial dysfunction. And if you remember going back to like 5th grade biology.
The powerhouse of the cell.
Yes, that's it. The powerhouse of the cell. Like, oh my God, ATP, metabolism, apoptosis, like all the important things for energy are not there anymore. And so there is a ton of sort of hypoxemia on the cellular level to the heart, leading to inflammation, edema, fibrosis. And it is a pretty severe insult to the heart. That's what's happening on the cellular level.
Okay. So we started with sepsis.
Yes.
And now the heart cells are like not having it. There's this whole inflammatory cascade and they're having a hard time adjusting to this infection in the system. Okay.
Big time.
All right. Back to our patient. So we successfully got the patient moved to the ICU. Okay. We maxed out our heated high flow. Patient's still having a hard time. I started the norepinephrine. I've been titrating up. I currently have it going at 0.3 micrograms per kilogram per minute. And I have a blood pressure of 90/50. Okay. We've kind of talked about maybe starting vasopressin for this refractory hypotension. We've discussed possibly dobutamine for some inotropic support because of this poor EF. Haven't started just yet. And then you have decided we need to intubate. We've kind of maxed out heated high flow. The patient couldn't tolerate the BiPAP. Okay. So we just basically, we're going to go for intubation. All right. Moody, this is where nursing and physician management intersect real fast, right? We have to collaborate because you have some great ideas and I have some great ideas and we're going to be implementing these things and patient's going to be changing as we're doing, like dynamic response from the patient. Yes. And so we have to be communicating, okay, I'm going up on the vasopressors, doctor. Do you want to add any more? Right. Or, you have to say like, I'm looking at the ultrasound and I see this, let's add this medication. Like 100%. This is such a dynamic interplay, which is what I love about critical care medicine. Okay. So how does your approach to fluids, vasopressors, inotropes change when dealing with sepsis-induced cardiomyopathy rather than just pure distributive shock? And what priorities are you communicating to the whole team?
Hey guys, I'll get back to the show in just 1 second. But before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show.
Okay. Great question. Great question. So the way I'm going to look at it is there's 2 buckets. So we've got septic shock here, we've got cardiogenic shock here, and now we've got this mixed bucket. So if I was dealing with purely septic shock, it would be, fluid, antibiotics, vasopressors. That's essentially all the management. The difference with cardiogenic shock is obviously you fix the cause and you give inotropes to make the heart squeeze better, and you try to take fluid away. So there are certain things in those management plans that contradict. The obvious ones are the fluid strategy, and the other obvious one is the vasopressor versus inotrope strategy. So in terms of the fluid strategy, we're kind of hitting sort of in a direct conflict. So in septic shock, we want to be giving fluids. In cardiogenic shock, we want to be taking off fluids. So in this patient, where I'm very concerned that he is on the fluid overloaded side, I'm leaning towards the cardiogenic shock trumps, and we need to focus on getting fluid off. We are definitely not going to be giving more fluid. If anything, we're reaching for a diuretic. We're trying to decongest the heart, take the pressure off the heart. So in terms of fluid strategy, that's kind of how I'm working through it. In terms of support hemodynamically, things get really messy really quickly in this situation because people often sort of conflate and synonymize inotropes and vasopressors. But one thing that I really like to harp on is that these are completely different medications. So vasopressors squeeze blood vessels and they raise the total peripheral resistance. And the reason it's important to pay attention to that is one of the blood vessels that they squeeze is the aorta. And so vasopressors increase afterload. That means that they make a sick heart have to work harder to pump blood around the body. We don't want to do that in cardiogenic shock, right? We want to do that in septic shock. In cardiogenic shock, what we want to do is ideally we want to decrease that afterload. We don't want the heart working hard, and we want to help the heart to pump better and faster. Now, the funny thing is most of the medications that make the heart pump harder and faster are also vasodilators. So whether you look at dobutamine or milrinone or whatever you're going to look at, they tend to be vasodilators. Now, there are some exceptions to that rule, like epinephrine is a really cool medication, for example. But all this to say that in this patient, I need to find a balance between increasing the total peripheral resistance and squeezing blood vessels while also supporting the heart. So that is going to be a bit tricky. And that's probably where vasopressin comes in. I don't know if you want to talk about vasopressin next.
Vasopressin works in a totally different pathway. So let's talk about how it kind of can be thrown into the mix to make things better all around. Go for it.
Okay, cool. Well, one thing that comes to my mind with this patient at 0.3 mics per kilo per minute and still being a little bit hypotensive is hopefully at this point we have a good access, right? Because at this point, if we're running through a peripheral lines are great, but it sounds like we're still not reaching our plateau on our vasopressors. And so at this point, I'm thinking, especially if we're about to intubate, hopefully we have a good line that we can work with, ideally a central line. The other thing that comes to mind with vasopressin, I love vasopressin. It's a really dynamic medication. It's basically ADH, right? It's that hormone that's made in our brains and released to our body. It reabsorbs water from the collecting duct of the kidneys. It also acts directly on V1 receptors in the blood vessels to cause vasoconstriction. So it's sort of a catecholamine sparing vasopressor. So it's great. But the thing with vasopressin is it is also reabsorbing water. And we have a patient with cardiogenic shock. And do we want to be reabsorbing water and increasing afterload? Is the heart going to be able to tolerate that? Now, the funny thing is, what does the data show? The data shows big question mark. We do not know. We do not know when to add on vasopressin in sepsis-induced cardiomyopathy. We do not know if starting it early versus starting it late is harmful. And actually, there's some evidence that vasopressin has a little bit of a positive inotropic effect, which would be really helpful in this sepsis-induced cardiomyopathy. So the reality is, for me personally in this situation, I am going to be adding vaso because our norepi is getting to high doses. We have a sick heart. We have a weak heart, and it's going to get tired and it's going to go into some weird, scary arrhythmia if we keep on cranking the norepi. So my vote would be to add the vaso through a central line because we need a catecholamine sparing vasopressor. I'm ranting a lot.
No, I love it. Like, rant on the literature. I'm here for it. I wanted to go back to our talk about how this is such an interdisciplinary adventure.
Yes.
I see a lot, especially in the ER, is that the doctor orders, say, norepinephrine titrate to get a MAP greater than 65. No problem. The nurse starts it. They're titrating. They are achieving the goal that they're carrying out the doctor's orders. They are getting the MAP they want. But they've gone from 0.02 mics to 0.8 mics in a half hour or even 1 hour. And they didn't tell the doctor. They're just like, I did it. I fixed the blood pressure with this infusion. But I think that the takeaway here is if you're having to double, triple, quadruple your dose to achieve the goal MAP, you should probably be letting someone know. It may be time to add something else in because clearly norepinephrine alone is not cutting it for this patient. They're requiring so much, which we know can be problematic as well when you're clamping down those pipes and you have a weak heart trying to squeeze against them. And so that's why as a nurse, if I'm getting to 0.3 mics of norepinephrine, I am definitely being like, hey, Moody, did you want to add something else? Did you want to take a peek and see what's happening with the patient? This is not... it's not giving us the intended result. I mean, yes, I have a good blood pressure, but like, why is it requiring so much, right? And is it time to add vasopressin? Is this something we need to add an inotrope to, which we already know because you did an ultrasound, but maybe we didn't. Maybe we just started norepinephrine treating a blind shock state. We don't actually know what the source is. Maybe it's time to do some more investigation to make sure we're treating the right thing.
Yes, two things. If I can hop in, Sarah, because those are such good points that you're bringing up, and I want to make sure that I highlight them. And there was, because you're giving out so many great ideas, and I'm just like connecting to it. So one thing that I thought of was at this point, if we're adding a second vasopressor, I am reaching for stress dose steroids. So that consists of hydrocortisone, 200 milligrams IV once a day, and fludrocortisone, 50 micrograms enterally once a day. And the reason, most of the data we have for stress dose steroids is that it improves catecholamine responsiveness and it reduces the time that their patients are on vasopressors in septic shock. But I still think since we have this mixed shock going on, I would be adding stress dose steroids. And the second thing I wanted to talk about was what you were saying, which is even more important than anything I've said so far, which is the communication aspect. This is a multidisciplinary effort, and it's so important that we are all communicating back and forth. If I just put an order into a computer, like you said, I don't talk to the team, we don't have a good communication going, and the vasopressors are quadrupling and I don't know about it, that's on me. I need to be able to talk to the staff, talk to the team, and make sure that we're communicating. Because I always tell people, textbook septic shock, yes, the pressures go up and up and up, but eventually they plateau. If you're tripling, quadrupling, quintupling, like something is going wrong. And I have a nice fancy dandy algorithm that I go through in those situations that we can sort of derail to if you want to, which is when the vasopressors stop working in septic shock in general. But that is not normal. That is not the natural progression of septic shock for the vasopressors to go from 0.05 to 0.1 to 0.8 to 2 to 3. You are missing something big time.
For sure. Yeah. And just to add to that, that goes with anything. If you're like increasing your oxygen flow, they were at 4 liters and now they're on a non-rebreather. Okay, maybe you fix the number on the monitor, but like someone needs to know something has changed in your patient. If you're going up on the vasopressor, there any intervention you're doing where you have the freedom as a nurse to titrate to get a set parameter goal, you still need to let someone know if things are rapidly changing in your intervention.
Right.
Very good.
Right. Yeah, and the timeline too. Like if someone is going like significantly worsening very rapidly, you see that they're basically nosediving. And in a few hours, you're going to run out of how much oxygen you can give them non-invasively,
Yeah, for sure. All right, I wanted to go back to the idea of intubating this patient. I have concerns.
Same.
It seems like we do need to intubate. Based on all of our interventions, they're not responding like we want. The x-ray is worse. And we need to intubate. However, there's lots of risk we're going to have to mitigate. Can you talk a little bit about how you would optimize this patient prior to shoving a tube in? Well, mainly 100%. Given the RSI to shove the tube in.
100%, right? I mean, we always talk about this, that you want to adequately resuscitate the patient because all the medications that we give as induction agents, whatever it is, they are going to in some degree affect our hemodynamics. Now, obviously, they do that to varying degrees, and the choice of induction agent is very important. So propofol, for example, would be a harmful choice in this situation. We would not be giving propofol, which causes profound vasodilation and stresses an already sick heart. So propofol is all the way out. So we're probably looking at some combination of either etomidate or ketamine. People generally tend to nowadays really, really love, the special K, the vitamin K, because ketamine actually increases your cardiac output. So it's not going to drop your cardiac output. Now, ketamine does rely a lot on endogenous catecholamines. And there's this idea that if the patient has already run out of gas, that once you push the ketamine, you might actually get this paradoxical hypotension. I trained in an area where we used a ton of etomidate, and I have had great experience with it. So my personal bias is I use a lot of etomidate. The hate that goes towards etomidate in terms of the street cred of etomidate is because we know that it causes some suppression of a specific adrenal enzyme. And we know that a lot of our patients have adrenal insufficiency, and we worry about adrenal insufficiency and septic shock. So that's the hate that etomidate gets. And also, we don't know whether giving exogenous adrenal hormones makes up for inhibiting this enzyme. Now, in my personal experience, have I pushed etomidate and felt like that killed the patient? I have not seen that, but I admit this is my personal bias. So one thing is choosing an induction agent that is not going to harm our patient. The second thing is going to be trying to, you want to always start intubation at a high ceiling so you have room to fall. So we need to find a way to get that oxygen as high as we can. So I know it's very unfortunate, by the way, that this patient can't tolerate BiPAP, because this would have been a class A indication for BiPAP. Like pulmonary edema, this is one of the places where BiPAP is extremely helpful. So even if we could get that patient to put the mask on, even for like 5 minutes to pre-oxygenate before we intubate, that would be extremely helpful. We know from recent trials that have been done that pre-oxygenating with BiPAP is superior to pre-oxygenating with an ambu-vac. So if we can get that BiPAP on, even if it's between pushing our induction agent and our paralytic, that's called delayed sequence intubation versus rapid sequence. The rapid sequence, you slam your induction and your paralytic at the same time. With delayed sequence, where you have people who are agitated or you want to pre-oxygenate them, but they're not cooperating, you can hit them with the induction agent. They go out, and now you can put something on and pre-oxygenate them and then hit them with the paralytic. So that might be one thing to consider. And then hemodynamically, we know fluids are out of the picture. We got to maximize on our norepi. There's still room to go up. I always tell people, they're like, oh, we're max on norepi. And I'm like, what are you at? Because there's no max, So 0.3 mics per kilo per minute is high, but it's not max. You can go crank it up, And if we've got the central line, let's throw the vaso in, because we need that blood pressure at least at a MAP of 65 before we push induction agents to make sure we don't crank it down. I would also say in the middle of the chaos, it's a good time to get a blood gas here, because we know that this patient is hypoxemic, which is a risk for peri-intubation mortality. This patient is hypotensive, which is a risk for peri-intubation mortality. This patient has a sick heart, which is a risk for peri-intubation mortality. And it would be helpful to know, are they also acidotic? Because then, oh my God, this is the perfect storm. And is there anything I can do to improve that acidosis before I push my induction agents? And I'm going to throw this out here. There is a drug called sodium bicarb that exists. Okay. Oh my God. One of the most controversial medicines in the critical care world right now is sodium bicarbonate. And granted, yes, we have to be mindful of how we're giving it. So the hypertonic amp form is different than the isotonic saline form. And we have to be mindful of who we're giving it to. But let's say we did get a gas on this gentleman and his pH was 6.9.
Oh gosh.
Yeah, I know, right? And his bicarb was 3. Would I give him bicarb? 100%, yes. And I'd be very confused as to someone arguing why we should not give this gentleman bicarb, at least temporarily, to stabilize him and reduce his risk of coding while we're intubating. So just putting that out there.
No, that's a good point. I think too, people, they are correct to have some caution with giving sodium bicarb, right? We used to just give it to everybody, but there is some consequences of it.
Totally.
But when you weigh out risk versus benefit, you said that bicarb is 3. I'm thinking the benefits outweigh the risk here.
Right.
Additionally, if I'm, say, the one bagging the patient, pre-oxygenating prior to the intubation, or even after the tube's in, bagging the patient, if I know we've pushed bicarb, I'm probably going to bag a little bit faster
100%.
And make sure we can blow off that CO2, because in case y'all didn't know, sodium bicarb actually breaks out down to CO2 and water. And so if we're pushing bicarb to help bump the pH, we're also going to eventually have a little CO2 we have to deal with. And you deal with CO2 by blowing it off. So
Correct.
We're not just going to set the vent at 12 breaths per minute right after we intubate this super sick person. We're going to have to be aware of metabolically what's going on and how we can support the metabolic system with the respiratory side of things. So
100%. Well said, Sarah. So well said.
Okay. So just to review, we are preparing for intubation. We are collaborating as a team to get the blood pressure higher than probably higher than 65 MAP. Personally, I want to be a little higher just to have some wiggle room.
Same.
Because I can't just bolus this patient with fluids to bump the blood pressure up whenever they have that transient drop from the RSI.
Correct.
Additionally, their blood pressure is probably going to drop too because of the positive pressure ventilations.
Well said.
And so I want the blood pressure, I'm thinking 130.
100%.
Is that okay with you? 130 systolic, and then I feel comfortable pushing the RSI in. We're going to pre-oxygenate as much as we can. If the patient's not tolerating pre-oxygenation, then maybe we can push a little ketamine or something to calm them, and then appropriately pre-oxygenate before we go trying to intubate the patient.
Yes.
Access-wise,
Yes.
Personally, as a nurse, I want 2 accesses before I go with intubating this patient. So maybe you got a central line in, maybe you're super fast with that, or at least I have 2 good working IVs before
Right.
It really sucks when you push RSI and then you lose your IV. It really, really sucks. And so I just want to make sure I have a backup plan for that particular situation, speaking from experience. Okay. All right. So we have worked together collaboratively. We have optimized this patient. We got the tube in successfully. It's days later, and our patient is actually recovering, Moody. It worked. All the things, all the literature we applied to practice, the patient's improving. So the patient is gradually recovering. We are weaning the vasopressors. We are preparing for extubation. Like, this patient's doing surprisingly well. Okay.
Amazing.
I wanted to point out that one of the most fascinating aspects of sepsis-induced cardiomyopathy is its reversibility.
Right.
Like, with close monitoring, quickly responding to all the hemodynamic changes of this dual shock state, these patients actually can recover pretty well. So can you share what your role is in moving these patients towards recovery? Like, how do you see the physician and nursing roles working together in the ongoing care of this patient moving towards leaving the ICU?
Absolutely. I think, I love that you've highlighted so many important examples in this patient's care where we just rely on each other so heavily, So when you were even going back to the intubation side, I love to empower, someone in the room to say, hey, I'm going to be focusing on the airway. So if you could just keep an eye on that blood pressure, and you have full liberty to titrate that vasopressor to get it to where we need to, So I totally agree with you that everything in this patient's care, and probably the reason why he survived to this point, is because of good communication, good collaborative effort. What I will say is I want to mention about the sepsis-induced cardiomyopathy, like the natural progression of the illness. You're absolutely right that as far as we know, a lot of these patients do recover their EF spontaneously once the sepsis has resolved. I did find a really interesting article that came out in Chest a couple of months ago, and they were talking about how this is probably one of the most poorly understood and under-recognized disease states. So I'm so glad we're doing a pod on it, because we really know so little about it. And a lot of it is because there's no universal criteria for diagnosing it. A lot of it is because maybe a lack of awareness, that people don't realize that that is what they're dealing with. And another part of it is it's a lot more heterogeneous than we thought. So the textbook sepsis-induced cardiomyopathy patient is the one that you described, the one with a low EF, just had sepsis, makes a lot of sense. But actually, they've now categorized them into like 4 types. Like, one of them has low EF, one of them is hyperdynamic EF, which is really an interesting type because, we see that a lot of the time when patients have septic shock, we get an echo and the EF is greater than 75%. And we're like, oh, great, the heart's just doing what we want it to do. But that actually might be a form of sepsis-induced cardiomyopathy in itself. And interestingly, they found increased mortality at both extreme ends of the spectrum. So people who have really low EF and people who have really high EF tend to have worse outcomes in the short term. And then the third and fourth group, so there's the low EF, there's the hyperdynamic EF, and then there's the diastolic dysfunction group of the LV, and then the RV failure. So all this to say that, yes, the patient that we highlighted here is a great example and the textbook example, and probably will recover his EF, but there is so much like nuance to this, and there are so many different types to it. Now, in terms of his recovery, I think the biggest thing is going to be safely getting him extubated, and then making sure that we do everything we can to set this person up for success and not to have them come back in and be this sick. So, is their diabetes under control? Are their medications optimized for their heart and for their infection? Did we confirm, the antibiotics we're going to be on, how long we're going to be on them? And then education, like so much education, and that you just survived a life-threatening illness. You had heart failure, you had all these things, water intake, salt intake, this is going to be such a mammoth. And this is the beauty of the ICU. Like, this is when we're pulling in like the doctor, the nurse, the physical therapist, the speech therapist, the dietitian, the caseworker. Where is he going to go after? Like, all those things kind of come together, so important to get this person forward. And then we know like things like post-intensive care syndrome and like mental health disorders after being in the ICU. So there is going to be so much left. It's great that he survived, but we want to make sure that now he survives with a good functional and psychological and social outcome,
Amen. Well, Moody, it's so unfortunate we don't do this in real life. This was so much fun. We would be such a badass interdisciplinary team, right? We have so much fun. But I really had a blast talking this case with you. Thank you so much. I want to say this case really highlights how sepsis can affect not only vasculature and cause life-threatening vasodilation, but also potentially the heart.
Yes.
And I don't think we fully understand how frequently it does affect the heart. I think we just get so focused on the sepsis pathway, we might lose sight, especially with the hyperdynamic. I don't know that I would have picked up on that either. That's really interesting. But yeah, it's super critical that team recognize this sepsis-induced cardiomyopathy early. Okay. Before I let you go, two things. One, can you give us just like a rapid fire pearls and pitfalls of managing this patient? And then I want people to know where they can find you. So first, pitfalls, ready, go.
Okay, go. So first things first, if your patient is not responding appropriately to the therapy you're giving, think outside the box.
Okay.
Secondly, make sure that in this intersect between sepsis and heart failure, that you're managing fluids appropriately, and that you're balancing vasopressors with inodilators to achieve the optimal hemodynamic performance for that patient. And then, thirdly, I would just say, communication, like you said, you need to create an environment with your team where people feel comfortable to pick up the phone and call you and say, hey, I don't think this patient's responding appropriately. Something feels off. Can you come lay eyes or can you come take a look? So we work better together, and like this prehistoric model where it's just the doctor do this, do that, and then everyone else listening to them. That's not how we work anymore. And so it's really important that everyone understand that we are equal members of the team, that we empower each other to speak up when something is wrong. I would say those are probably my key points.
Yes, those would be mine too. I meant all of those. All right, before I let you go, ICU boy, can you tell people where they can find you if they wanted some more evidence-based practical pearls and nerdy pathophysiology?
Thanks so much, Sarah. So my alter ego is ICU boy. So you can find me at ICUboy_meded on Instagram, TikTok, X, and Threads. And then on Facebook, they don't allow an underscore. So I'm just at ICUboyMedEd. And I'd love to see you all there. And thank you so much, Sarah. This was like a blast. And I'm still low-key, not even low-key, high-key hoping that in the future we end up working together, because I just feel like it would be so much fun.
Hashtag goals. Yes, that'd be awesome. All right. Well, I will put a link to all your stuff in the show notes. You guys wanted to check them out? Thank you so much for joining us. I have so enjoyed this case-based format and learning something new. If you've enjoyed this, make sure you subscribe and share with your colleagues. So until next time, stay curious and keep learning. Thanks so much.
Bye.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.